Okay, let's talk about a differential diagnosis, and then I'll talk a little bit about the femoral triangle and those important anatomy before I move further. This is also very important, slide. What are the differential diagnosis of, inguinal hernia? All mass which is present in the inguinal region is not inguinal hernia. That is the first thing you like to, consider. Yes, inguinal hernias are very common, but not all the time. So the differential diagnosis of an inguinal hernia in a male is hydrocele of processus vaginalis. Hydrocele of processus vaginalis is one of them. See there? And we all know what is processus vaginalis, isn't it? It's a piece of peritoneum, okay, which is coming downwards from the abdominal cavity. Hydrocele of spermatic cord. Varicocele. Now this varicocele is the distension of pampiniform venous plexus. So let me write that for you. Distension of pampiniform venous plexus. And this pampiniform venous plexus, okay, they are present inside the spermatic cord. And they are the vein which drains the testes and the epididymis. These are the vein which drains the testes. And later on, all these veins will fuse together and form testicular vein. So this dilatation or distension of this type of venous plexus is known as varicocele. This is not that very serious condition, but if it is not treated in time, because of the temperature imbalance there, because that one will cause all the time a little bit, hot type of temperature there, or increased temperature, which will not allow spermatogenesis to occur. So varicocele over a long period of time is not good for that male, and it can be treated well. Another one is undescended testes. This is an important differential diagnosis. This undescended testes means the testes is not descended well into the scrotal sac. Now remember, this testicular descent occurs around the term, means around the 40th week of gestation. Okay, if a baby is born prematurely, then testes is still not descended. They are still in the inguinal area or even inside the abdominal cavity. It depends on what is the period of gestation. Now the point here is, even after the baby is term, okay, after the birth of the baby, if the testes are still undescended, then we need to find out the cause, or we need to go for the treatment. And one important point, though this is not the topic we are talking about, if undescended testes is not treated in time, two very important complications can occur. One, testicular tumor development, and second, sterility. The testes, okay, function of the testes will be gone because there is too much temperature inside the abdominal cavity. And for the spermatogenesis, relatively lower body temperature is necessary. So what are the two complications now? Testicular tumor and sterility in case of that boy. So what the message you have learned? If any child, okay, was brought to you with undescended testes complaint from the parents, take it very seriously. Don't say, oh, it will descend after some time. Don't say that. Just plan for the surgery. Surgery is very easy there. It is called fixation of the testes on the wall of the scrotum. This is known as orchidoplexy. Now, another one is lipoma of the spermatic cord. Lipoma is a tumor, is a benign tumor which originates from adipose tissue. So these are some of the differential diagnoses. Now, in female, consider hydrocele of canal of Nuck. Okay, hydrocele of canal of Nuck. Now, this canal of Nuck is the abnormal patent pouch of peritoneum extending into the labia majora of woman. So it is analogous to patent processus vaginalis in case of male. So it is a similar type of structure there. Processus vaginalis, in male, canal of Nuck in case of female. If it is still persisting there, then some fluid can collect there, which is known as hydrocele of canal of Nuck. For both sex, we should always consider femoral hernia. Femoral hernia is a very important differential diagnosis of inguinal hernia. Okay. But before I go into the femoral hernia, okay, let me talk a little bit about the femoral triangle and the femoral canal. Now, please listen carefully. You can also, consult some of your anatomy textbook if you want to learn a bit more. Okay, but I'll make it very easy for you. The femoral triangle is the anatomical structure which is present in upper 1/3 of the thigh. So it is present in the upper part of the thigh, and it is present below the inguinal ligament. It is present below the inguinal ligament. These are very important points. So you know where is the location. Now, what are the boundaries here? Okay, so it has just like a inguinal canal. It has a different boundaries there. Like superiorly, okay, superiorly there is an inguinal ligament. Medially, there is a medial border of adductor longus muscle, because adductor longus is a muscle of anterior aspect of the thigh. Okay, this is the medial compartment of the thigh, we say, and this is adductor longus muscle. Laterally, we have medial border of sartorius muscle. Now, sartorius is a very long muscle which is present again in the anterior compartment of the thigh. Okay. This muscle belongs to the extensor group of the muscles there. So superiorly, inguinal ligament, medially, medial border of adductor longus, and laterally, medial border of sartorius. So this is a triangle-like structure which is known as femoral triangle. The apex of the triangle is present inferiorly. Okay, inferiorly. Now, roof is formed by skin, subcutaneous tissue or superficial fascia, and fascia lata. Now, this fascia lata is called the deep fascia of the thigh. Okay, deep fascia of the thigh. Now, there are some important, structure present in the roof. There are superficial inguinal lymph node, which is present on the roof of femoral triangle. And superficial inguinal lymph nodes are important because they drain the nearby area. Okay, mainly the genitalia, the superficial aspect of the lower limbs, okay, and the nearby area. Now, regarding the floor, there is the floor of the femoral triangle is formed by pectineus muscle mainly, pectineus muscle, and adductor longus in the medial side, and iliopsoas muscle in the lateral side. So these are the boundaries of femoral triangle. Now the important point we are reaching here, what are the contents of the femoral triangle? So the important contents are femoral nerve, okay, femoral artery, femoral vein, and femoral canal. Now, let me say it again. Femoral nerve, femoral artery, femoral vein, and femoral canal. Now, all of these are present from the lateral to medial aspect. Femoral canal is the medialmost structure. And this femoral canal is the area where femoral hernia occurs. This is the relation. Okay, femoral canal has femoral ring at its topmost site, and from that femoral ring, the hernia enters into the femoral canal. That femoral ring is a narrow structure, so usually the hernia presents as obstructed hernia or strangulated hernia also. Now, one very important, anatomical knowledge you should have: what is the content of the femoral canal? What is the content? There is a deep inguinal lymph node which is present inside the femoral canal. Never forget it. Deep inguinal lymph node is present inside the femoral canal. And the function of this deep inguinal lymph node is, it is draining glans penis in male, clitoris in female, and it also receives, okay, drainage from superficial inguinal lymph node. So from this femoral canal, femoral herniation occurs. So that much information I like to provide. Now let's come back to our slide here. So see this, clinically, how we know. Femoral hernia, this may extend above the inguinal ligament after passing through the fossa ovalis femoris. Now this fossa ovalis femoris means through this, it is also known as the saphenous opening, and this saphenous opening is the opening for long saphenous vein which drains into the femoral vein. So there is one other opening there. Through that opening, the femoral hernia may come out and again ascend up. Okay, again ascend up if it's a big one. But if the examining finger is placed on the pubic tubercle, the neck of a sac of a femoral hernia lies lateral and below, while that of an inguinal lies above. So what is the meaning here? Pubic tubercle is the area where inguinal ligament is inserted. Okay, inguinal ligament is inserted there. And we already talked about femoral triangle is below the inguinal ligament. Okay, so femoral hernia lies lateral and below the pubic tubercle, whereas inguinal hernia definitely lies above. Now, another, a differential diagnosis for inguinal hernia is lymphadenopathy or abscesses of the groin. Remember, there are superficial inguinal group of lymph nodes and deep inguinal lymph nodes in the femoral triangle. If they become big, we can get confused. But there are so many other related situations there. Residual hematoma following trauma or spontaneous hemorrhage in patient taking anticoagulant drug can be some other differential diagnosis because it may present as a mass. Now, with this discussion, let us enter into the treatment part. What is the treatment of hernia? Now, the most important treatment of the hernia is surgical. We need to repair the hernia. So, repair of inguinal hernia should be done. Surgery is the only curative procedure for inguinal hernia. There are no lesser therapies that have proved effective. There is no role of any medical management there. There are no drugs which will decrease the herniation. Always remember that. It is always surgery. Now, see this. A study has reported that the risk of incarceration is low in minimally symptomatic hernia and that observing them is a safe alternative. So this was published in JAMA. Okay. This is a renowned journal. So what that study says, the risk of incarceration means obstruction is low in minimally symptomatic hernia and that observing them is a safe alternative. So we can observe them for certain duration, but remember, they can become symptomatic anytime. They can develop obstruction or strangulation anytime. So the safer option is always, according to the patient's wish, according to the appropriate time, we should plan for elective surgery. Don't wait for emergency surgery to happen. Okay, uh, we plan elective surgery for the treatment of hernia. Now, see this, surgery is the treatment of choice and there are two important options for us: herniotomy and herniorrhaphy. Herniotomy and herniorrhaphy. Okay, we'll talk about this. Surgery is either open or laparoscopic. Open means the conventional surgery, you just give an incision there and do everything, and laparoscopic with the help of a laparoscope instrument. Regarding the anesthesia, operation is usually performed under general anesthetic. In patient with poor cardiovascular or respiratory function, epidural or even spinal anesthesia may be used because general anesthesia may be dangerous in them. That is the reason. Some surgeons repair inguinal hernia under even local anesthetic. So if both general anesthetic and spinal anesthetic are a bit of risky, then you can also go for local anesthetic. Okay, some of the surgeon can even do like that. And one important point: any hernia can strangulate. So the point here is plan for surgery before it strangulate or it develops some complication. That should be done. Okay, and that is considered as a good surgeon. Now, what is herniotomy? The basic operation of inguinal herniotomy entails dissecting out and opening the hernial sac. See this? You dissect out and open the hernial sac first. reduce any contents, whatever is inside. Usually the content is a piece of or loop of intestine, so you reduce it, and then transfix the neck of the sac and remove the remainder content. So this is known as herniotomy surgery. And remember, this surgery is very commonly done for indirect inguinal hernia. Indirect inguinal hernia, especially if the patient is very young, like children, okay, adolescent or young adult, only herniotomy is enough or sufficient. Now, why? Because the tone of the anterior abdominal wall muscle or the muscles are still stronger in that age group. The muscles are not flabby or floppy like an old person. That's why herniotomy alone may be enough in them. But the decision is always done by the surgeon who is doing the surgery. If the surgeon believes I need to transfix, okay, the posterior abdominal wall because it is already weak and there is a chance of recurrence of the hernia in the future, then okay, the surgery is known as herniorrhaphy. Okay, they will put some type of mesh there, okay, some type of transfixation type of surgery and make that area quite stronger. See this? What is herniorrhaphy? A herniorrhaphy generally refers to the operation for repair of an indirect or direct inguinal hernia, although it should apply to any hernia repair. And it can be performed by an open or laparoscopic technique. But the main difference between herniotomy and herniorrhaphy is we reinforce, okay, the posterior abdominal wall, especially in case of herniorrhaphy. We want to make that part stronger, okay, by doing some surgical procedure. This is known as herniorrhaphy. So herniorrhaphy is the combination of herniotomy and repair. Consists of the following things. First of all, you excise the hernial sac. Along with that, you repair the stretched internal inguinal ring or deep inguinal ring and the transversalis fascia. You repair that because transversalis fascia may become very weak there. Okay, it may be, you know, a bit of stretch also, and there is further reinforcement of the posterior wall of the inguinal canal. So clearly, okay, we are doing some surgical procedure there to make that site stronger. This is known as herniorrhaphy. The step 2, that is repair of the stretched internal inguinal ring or deep inguinal ring and the transversalis fascia, and the step 3, that is further reinforcement of the posterior wall of the inguinal canal, must be achieved without tension, resulting in the wound, and various techniques exist to achieve this. So tension would be avoided. Tension means, you know, you should not pull those structure too much. So the different, you know, terms are there. One is called shoulder separation, that is 4-layer inguinal hernia repair, which is performed with the patient under local anesthesia. You can also apply some facial flaps or even implant of the mesh. This is artificial, you know, substance there to just make that area stronger. So many different surgeons, they like to do mesh repair also. So you don't need to know in this much detail, just know the surgical principle, you know, because you are the undergraduate student. So what is the surgical principle there? Make that area stronger so that the future recurrence of the hernia will not occur. Let's move on. Now, after the discussion of surgery, what are some other alternatives there? Now, in some of the patients, surgery is not advised or surgery may be highly risky. Okay, then what we go for? We go for truss application, a truss. So it may be used in those type of people and where the contraindication to surgery, you know, exist, like extremes of the age. If the person is more than 80 or 85-year-old, there may be so many other diseases in this patient, like hypertension, uncontrolled type of diabetes, okay, COPD, those type of things. So surgery may be risky. General debility, the person looks very sick or ill. Large direct hernia that is easily reduced, and patient elects to use truss. Now, you give the option to the patient. You just say, this is one of the options you can go for. And if patient elects for that option, then you need to, you need to say, okay, fine, it is your choice, and go for that option. Okay. So in that situation also, truss can be used. Now, let's move further. Okay. Now, some other important points regarding the surgery. What are the post-operative advice we should give to the patient after hernia repair or herniorrhaphy or herniotomy? The patient should be encouraged to walk as soon as possible. This may be facilitated by simple analgesia. So we can use certain analgesic drug there, because after the surgery there will be pain, and the analgesic drug can be NSAID or can be opioid analgesic. The person is still in the hospital, so you can go for opioid analgesic also. In the week following surgery, the patient should avoid activities which may strain the repair, like driving a car or lifting heavy weight. That should not be done. Otherwise, there may be high chance of recurrence. In the following few weeks, they should gradually return to the normal activity. The time at which a patient should return to work is dependent on the nature of the job and the rate of recovery of the patient. For example, somebody is working in the gym, and somebody are the laborer. So for them, the time given is more to return to the work. Somebody who is doing the office job, like a very easy type of job, they just sit on the chair and do their job. The time for return to work is earlier. So it depends on that. Patients generally return to work between 2 and 6 weeks post-operatively. The heavy manual work should not be commenced or recommenced before 6 to 8 weeks because of the increased intra-abdominal pressure, okay, and the wound is still not that properly healed. So there is some complication development, and patients should be wary of any activity which causes pain in the wound. Okay, so these are some of the post-operative advice. Don't ignore them. They are also very important one. Let's move on. Now, what are the chances of recurrence of the hernia? Okay, so that is discussed under prognosis. Indirect inguinal hernia recur in about 3% of the cases. 3% of the cases when a recognized operative repair is competently performed. So even if it is well done, then there is a chance of 3% of the cases. Okay, means the recurrence is there in 3% of the cases. So we need to explain that to the patient. For direct hernia, the figure may be as high as 28%. Now, let me ask this question to you. Why is this big difference between the chance of recurrence of direct hernia and indirect hernia? Anybody?
Because of the size, direct and large size.
Sir, direct hernia is occur in a very big area, so that's why recovery chances much more than indirect inguinal hernia.
Good point. Good. Okay. Anybody else? Anybody? I accept your explanation. Very nice. That is definitely one of them. Okay. Now listen here. This is a bit of clinical question. I have to go back. What are the causes of this hernia? And remember, in case of direct inguinal hernia, it occurs from Hasselbeck triangle. That area is relatively big. Absolutely agreed. And that posterior abdominal wall has to be very weak, then only the direct inguinal hernia can occur. So if that area is so weak that the recurrence chance is also higher. Whereas in indirect inguinal hernia, it occurs to the deep inguinal ring, enters into the inguinal canal and comes out. So the posterior abdominal wall is still, not that weak. So that type of explanation you can give. And one more thing, according to the surgery, direct inguinal hernia are always treated by herniorrhaphy, always. Without herniorrhaphy, the treatment is incomplete. Whereas indirect inguinal hernia can be only treated by herniotomy. Okay, if the surgeon believe or thinks the abdominal wall is still strong enough, they don't need to do the repair job there. Now, with this discussion, let's talk about what are the risk factors for recurrence of the hernia. Poor operation, there's no doubt about it. If operation was not done properly, if inexperienced person has done that, then it is a big problem. It may recur later on. Inherently poor musculature, inherently means the muscles are weak from the time of birth. Okay, chronic cough, especially in bronchitis, or people who continue to smoke immediately after the operation. If they continue to cough, that is the meaning. Cough will cause increase in intra-abdominal pressure. And if that pressure is high all the time, then there's definitely chance of recurrence. Urinary tract obstruction, same explanation. Person is strained during urination. That strain will again increase the intra-abdominal pressure. Constipation, same reason. Same reason. And premature return to heavy work, again the same reason. Because when they do that, there is again increase in intra-abdominal pressure, and that will help for the recurrence. Now, before I enter into some other types of hernia, okay, but the break time will also start probably by that time. I want all my students, okay, finally look at the differences between indirect and direct hernia. And in your exam, this question will be asked, okay. It's always asked, actually. It's 100% of the time this question is asked in the exam. See there? So we have included so many points here, though take it as like a revision for you. Regarding the age, indirect inguinal hernia usually occurs in children and young people, whereas direct hernia occurs in aged people. Pathway of protrusion. Now see this, okay? This pass through deep inguinal ring and come down to the inguinal canal, may also enter the scrotum. This is indirect hernia. Whereas direct hernia pass through the Hasselbeck's triangle and rarely enter the scrotum because of its big size. Because of its big size. Regarding the contours of the sac, contours means shape. It is elliptical and pear-shaped. And regarding the direct hernia, it has wide base and semi-spheric. This is not very important point. And this is difficult to remember also. Regarding the compression of the internal ring after reduction, that is deep ring occlusion test, okay, or ring occlusion test, which we have discussed already. Indirect hernia is controlled, okay, so the test is positive, whereas direct inguinal hernia is not controlled and the test is negative. Relationship of spermatic cord with the sac. Posterior to the sac is indirect hernia, anterior and lateral to the sac is the direct one. The relationship of sac neck with inferior epigastric artery. This is also very easy because Hasselbeck triangle is medial to the inferior epigastric blood vessels and deep inguinal ring is lateral. Now see this, the sac neck is lateral to the inferior epigastric artery, whereas sac neck is medial to the inferior epigastric artery in the direct inguinal hernia. Another one, the incidence of strangulation is high in the indirect one, again because of the narrow neck, whereas in direct it is low. Now, these are the things, okay, which you can do on your own, but let me choose some of the very important point which you should not forget. See this, uh, in indirect inguinal hernia, the patent or reopening of the processus vaginalis is quite common. Whereas in direct inguinal hernia, it mainly occurs because of weak abdominal wall or the muscle. That's why reinforcement technique has to be applied during the surgery. Okay. Another one, G-man's test. If you do that, impulse on the index finger and impulse on middle finger, it also depends on which finger is kept where. And these are the some other differences you can go. Okay, so please revise this. This is a very, very important. Fine. Now, after talking through all those different, aspects of inguinal hernia, let's talk about some other types of hernia, like umbilical hernia, like incisional hernia, and things like that. The umbilical hernia occurs through umbilicus, occurs through the defect where the umbilical structures pass through the abdominal wall. This umbilical hernia occurs much more common in female than in male. Now, there may be different reasons for that. Probably the anterior abdominal wall muscles are a little bit floppy or flabby in case of female. Okay, maybe contributed by prior pregnancies and things like that. But definitely, it is much more common in female. The defect is common in children, but usually closes by age 2 years, and fewer than 5% of the umbilical hernia persist into the later childhood and adult life. Now, let me clarify this, make it easy for you. Sometimes what happens, when we look at the site of umbilicus, it looks like a slight bulge there, okay, in case of a child. But later on, that bulge will disappear on its own. But sometimes only it persists there, okay. In some conditions like Down syndrome, there is umbilical hernia, and it is considered as one of the clinical feature of Down syndrome. And it occurs probably because of very floppy anterior abdominal wall musculature. Whereas in adult, umbilical hernia are often associated with increased intra-abdominal pressure, as with ascites or pregnancy in female and ascites in both sex. Ascites is a collection of free fluid in peritoneal cavity, and it is definitely causing increased abdominal pressure all the time, and that is leading to umbilical hernia. A good example is cirrhotic patient or chronic liver disease patient or patient who are having portal hypertension. Now, repair of an umbilical hernia consists of a simple transverse repair of the facial defect. So treatment is relatively easier than other types of hernia. Now, look at this. Okay, this is a picture of umbilical hernia. This is umbilical hernia. Now, another, small umbilical hernia here, but probably in this child, it will disappear after the child becomes bigger. Now, one small question I like to ask here. There are two terms or two clinical terms, okay, which are known as omphalocele, omphalocele, okay, and gastroschisis, and gastroschisis. Anybody can tell me what is the difference between them? Why I am bringing this point here? Anybody?
Uh,
Yes. If you are
sir,
not,
basically, sir,
yeah, sure.
sir, basically,
Go on.
sir, basically, sir, both of them are like sir birth defects. Sir, in which sir, like some of the very important organ are herniated out or sir, they are extending out, sir. But like the difference is that sir, basically, sir, in like sir, in the gastroschisis, sir, the protrusive organ are contained within a within a thin covered sac, sir. Sorry, sir, in omphalocele, but sir, in gastroschisis, the ball is free floating.
Okay, fine. Any
Yes,
other
sir,
students? Yeah.
in gastroschisis, ball is free floating, and the in other it is different. It is within the thin covering sac.
Okay. Okay. Good. The points are there. Okay. Now,
Sir,
yes.
amphalocele arises. Amphalocele arises with an umbilical ring.
Okay.
So,
Now see that. I cannot.
gastroschisis involves the bases of the umbilical stalk.
Okay. Now all of you please listen here. Okay. Some points are coming. Why I am bringing this point here? Because they're related. They are related with the bulging of the structure from intra-abdominal cavity. Now, umbilical hernia occurs right from the umbilical area, okay, right from the umbilical area. It is also associated with some defect there. There's no doubt. But omphalocele is a big type of defect of anterior abdominal wall. Sometimes the anterior abdominal wall is not formed at all, okay? But there must be a bigger defect around the umbilicus. So the intra-abdominal contents are herniated, but they are still covered with peritoneum. Still covered with peritoneum. That is omphalocele. Whereas gastroschisis is a similar type of condition. There is intra-abdominal contents visible from outside and they're bulging outside. And usually there is no anterior abdominal wall. It is not developed. This is not covered by peritoneum. It is bare there. It is naked there. Okay, so that's the difference. These are massive type of congenital anomaly where this umbilical hernia is considered not that very complicated one. Let's move on. Now, please mute yourself. The another type of hernia we are going to talk is called incisional hernia. Incisional hernia. So let me elaborate on this. This is the most common type of ventral hernia. Ventral hernia means it is coming from the ventral aspect of the intra-abdominal wall, which results from poor wound healing in a previous surgical incision. This is a very common surgery in case of abdominal wall known as laparotomy. Okay, laparotomy, and if that incision doesn't heal in time, then there is a high chance of incisional hernia. So many different surgery we do on the intra-abdominal wall. Now occurs in 5 to 10% of abdominal incision, so quite common. There is a protrusion of abdominal contents through a healed incision. Now let me clarify this. If the incision is still raw, okay, the surgical incision has just been sutured because of some infection right then, and if the intra-abdominal contents are coming out, this is not called incisional hernia. This is known as wound dehiscence. Wound dehiscence. Incisional hernia will occur only through the healed incision from this in the skin, but probably deeper down the fascia was not sutured well. Okay, probably there are lot of other risk factors. Probably the pressure inside the abdominal cavity is high all the time, so they are responsible for incisional hernia, but the incision on the skin is already well healed here. This is very important concept. What are the common causes of incisional hernia now? See this. Okay, so they include midline incision. Midline incision is not healed properly in time because of the poor blood supply there. Wound infection or hematoma, which doesn't allow the wound to heal properly, but not at this time. The herniation occur at this time, we don't call it incisional hernia, just talked about. Advanced age or older people, obese people, the person who are debilitated generally or having a malnutrition, a surgical technique which is poor, or a post-operative increase in abdominal pressure like in paralytic ileus, ascites, or pulmonary complications after surgery. In all of these, the intra-abdominal pressure is high, which will lead to herniation later on. Okay, let's move on. Now, how to make a diagnosis? The diagnosis will be apparent based on history and physical exam. History should be asked about what type of surgery was done in the past, when it was done, like that. And physical examination will give you the diagnosis. Now, once again, this is such an important point, so it is repeated. It is not the same as wound evisceration or wound dehiscence, where the abdominal contents are completely expelled. Okay, no lining or sac at all, and this is always considered a surgical emergency. Hernia has a sac, hernia has covering, hernia has content, but this wound evisceration probably doesn't have any lining or things like that, and it occurs quite earlier, okay, than incisional hernia. So these are the important point. Now, regarding the treatment, incisional hernia are repaired after the patient has recovered from the prior surgery trauma, and Repair requires definition of the adequate facial edges surrounding the defect, closure with non-absorbable suture, and use of prosthetic mesh like polypropylene when the defect is too large to be closed primarily. So let me explain this. You have to mainly focus on the fascia there. The fascia should be, sutured well, and usually non-absorbable sutures are used, like a proline. Okay, proline is a good example here. And if the defect is a bit bigger, then you can put a prosthetic mesh there. Okay, this is known as a repair surgery. So this is about incisional hernia. Now let's see some of the picture here. See there, this is incisional hernia. This is the incision. You can see right here, this incision is given. And through this incision, the herniation has occurred. This is a well-healed incision. See this? This is another, example of incisional hernia. See here, there is a big incision. You can see right there. Okay. Let's move on. There is another incision. This is a transverse type of incision, and through that, the incisional hernia has occurred. So these are the good pictures of the incisional hernia. Another type of hernia is called epigastric hernia. Now let's talk about it. Just some of the information. It results from a defect in the linea alba above the umbilicus, in the epigastric region. That's why it is known as epigastric hernia. So there is a defect in the linea alba above the umbilicus, and then the herniation can occur there. Now, herniation of intra-abdominal. First, let me ask you, what is linea alba? I'm sure you know this. Yes? Linea alba, what is that?
Sarmiai.
Yeah, sure.
It is a linea alba, sir. It is that fibrous line in the anterior abdominal wall. So it is formed by the fusion of the rectus sheet layer, and so it is medial to the bilateral rectus muscle, and it attaches the xiphoid process and the pubic symphysis.
Absolutely clear. Okay, very good. So this linea alba is the midline structure. Okay, this is now. Remember, right, on both sides of the midline in the anterior abdominal wall, we have two rectus abdominis muscle. Those rectus abdominis muscle are covered by rectus sheath. Okay, they are fused in the midline. This is known as linea alba. In obstetrics also we talked about this. This linea alba, okay, may become pigmented, a bit black pigmented in case of pregnancy, isn't it? We have studied that, especially not above the umbilicus. The more common is below the umbilicus, but in some of the ladies, it can get pigmented above the umbilicus also. That is called linea alba. Now, let's come to the point. Through that linea alba, okay, some herniation may occur in the epigastric region, and that is labeled as epigastric hernia. Herniation of intra-abdominal contents occur in this situation. It is more common in male now, in a 3:1 ratio, and some 20% of the epigastric hernias are multiple at the time of repair. Means multiple areas, because linea alba is a long line-like structure, so it may be multiple sometimes. And repair, that is simple suturing, is associated with a recurrence rate as high as 10%. It may recur. It is not a very serious type of herniation though. It can be handled quite well. Now, we have reached to the last slide of this big topic. Epigastric hernia and obturator hernia. What are those? Just the meaning, okay? Just the meaning. Now, epigastric hernia protrude to the abdominal wall along the semilunar line, that is linea semilunaris, and that is known as the lateral edge of the rectus muscle and rectus sheath, the lateral edge. That is relatively weak site. So through that, if the herniation occur, we call it epigastric hernia. And obturator hernia occurs through the obturator foramen, okay? Obturator foramen in the buttock area or upper part of the thigh on the back side, you can say. The hernia can cause pain along the obturator nerve, okay? So These are some of the important points.